Welcome to session Evolving Bifurcation Treatment Practices, Drug-Coated Balloons, Angio-based FFR, and Side Branch Optimization. Here's the conflict of interest. The session objectives are to discuss and explore current and potential use of drug-coated balloons in bifurcation treatment, which is, I think, one of the hottest topics at every interventional meeting in this year, with case illustrations and insights into the latest clinical data. Then to understand the importance of the CutWorks physiology-guided treatment strategies in avoiding unnecessary side branch interventions in provisional bifurcation stenting, and to examine side branch optimization techniques following main vessel stent implantation in large coronary bifurcations. My name is Goran Stankovic. My co-chair is Dr. Jens Flansted-Lassen, and we have three discussants, David Hildig-Smith, Ajay Kirtani, and Ajit Menon. Please use mobile application to ask your questions, but this is not such a big room. There are room microphones here. Please just think of your questions. We have fantastic experts presenting the latest data. Use this opportunity to get your answers. So with this, I would like to invite the first speaker, my colleague and friend David, to discuss DCB. David?
Thanks very much, Goran. Okay, so what I'm going to show actually is I'm going to show two cases because the data is quite dull on DCB and bifurcations and as yet unformed, awaiting a trial in which we use drug-coated balloons as a complete strategy versus provisional stent, and that's the early plug then for the EBC-DCB study, which is coming to a centre near you shortly. So, two cases. First case, this is a patient who had had a stent, about 70, had had a stent to the LAD with angina, continued to have angina, was known to have an aberrant right coronary artery, which hadn't been imaged, but on the CT scan it was clear that there was disease in it. So, actually, out of interest, just to say, I would normally try and get in these with an XB guide, but neither an AL nor an XB went anywhere near it. And in fact, it was rather strange. I had a JL4 just positioned essentially upside down. And then a bit of fly fishing rather agreeably allowed the wire to go straight in. So I thought, okay, we'll take that. Then, because we weren't very sure about how the support was going to be, we passed two wires. And if I just maybe take you back to I'll take you back to this picture. Sorry. Oh, it never quite works, does it? Forget that. We'll continue. So I don't know if you saw, basically in the vessel where it separates with the aberrant circumflex, there was a sort of 101 lesion. It will be visible again in a minute. So we used the balloon actually as a sort of bouncing technology to get into the circumflex because it was a slightly funny angle. Actually, I'm not sure it did anything, but it was a nice try. And then this is a very different mindset to what you do with ordinary angioplasties, old angioplasty, as I like to call it now, where you put a stent in. This is quite different. This is new angioplasty. And what you do is a lot more preparation, a lot more thought, a lot more time, more gentle, sequential inflations, ancillary devices, cutting, scoring, etc. So here we're just inflating one-to-one in the what you would call the side branch, which is effectively the circumflex off the main stem. And then you can see this initial result. So where the lesions were, I hope you can see clearly, were just here before the bifurcation and tightly just here after the bifurcation. And this is how it's looking. So far so good. No loss of antegrade flow, no dye staining with what we've done so far. So we're getting along nicely. And in fact, I thought, oh, we are getting on nicely. Let's open the blockage that's at the bottom as well. I don't know if you could see that, but the posterolateral was all missing. And agreeably, a Gaia second made swift progress into that. So we pre-dilated that. So we've now got two bifurcations that we're dealing with, and we'll deal with them in different ways. So having done that and opened the posterolateral, we're then wanting to get the best result that we can before applying the drug to the main vessel. So here, I hope you can see it's a slightly funny looking balloon. It's a scoring balloon that has a wire on the outside as well as the secondary wire that we have that's a buddy wire. So we're cutting in two different places. And we've done that in the mid vessel and proximally to the bifurcation. So now we have this view, and I'm sure quite a few people are thinking, oh God, what a horrible mess. For goodness sake, can you put a stent in, please? Because, you have to get used to the fact that it does look a bit messy. But what you can see here is the posterolateral is open and is much bigger, actually, than the PDA. There's disease here which needs attention. Most of this is doing not too badly. We've brought some of that up. Maybe needs a little bit more work. So firstly, what we did was decide, okay, we're going to finish off with the CTO bifurcation at the bottom. We're going to prioritize the posterolateral. We're not going to treat both limbs, because often you don't if there's not significant disease in the ostium of the secondary branch. So we've pre-dilated further, and then drug-coated balloon, I can't remember, maybe 275 by 20 Prevail to the posterolateral. Following that, this is a patient with some renal failure, so we're trying to preserve dye. We've then essentially done, on the main bifurcation up here, we've essentially done main, side, side, main. That's the strategy. So preparation of the main vessel, preparation of the side vessel, and now we're at the point, and we've done that, where it's going to be, okay, just lay the drug on gently, so a 3x35 device here, maybe to 8 atmospheres, just to lay the drug on. And then the same for the main vessel, 3.5 by 40. And that now gives us our final result. So in some respects, yes, you look at it and think, oh, it's quite ugly, would have looked a lot prettier with some stents in. But that's not the point. The point is to get rid of the patient's angina and to have what ends up being an angina-free good result for a good long period of time. And stents have, stents are brilliant, but they have their pros and cons. And in this kind of anatomy, really good to be able to avoid putting stents in complex anatomy. So that was a slightly strange one. I'll show a slightly more, if you like, normal one, which is going to be the kind of case that will be in the EBC-DCB study. So this is LAD diagonal bifurcation. So this patient was about 70 as well, male, had angina and had a perfusion scan suggesting lots of dropout anteriorly. He had also had a CT scan which suggested CT-FFR was positive in the LAD specifically, as well as obviously the diagonal, which is very tightly narrowed. Anyway, we took a couple of pictures to try and be clear, do we need to fix the LAD as well? We felt that this was, at the first diagonal, sufficiently narrow, bearing in mind the history and the imaging, that we would treat that as well as the diagonal. So this is now going to be a classic main side, side main approach. And again, what we're doing is we're using pre-dilatation 1-to-1. It takes some time to get used to doing that because we've sort of used mentally to doing not quite 1-to-1 and then putting in a stent. So here we have a cutting balloon, 3x15, a little bit more cutting balloon, 3x15. We see whether we think that's adequate, and this takes a little bit of time, slow, a whole minute for the inflation. Not massively high pressures because then you lose the effectiveness of the cut. This is now a bigger one, a 3.5 by 10 maybe, cutting balloon. So we're slowly chipping away, working our way at making this lesion as good as we can get. And you can see the whole LAD has actually come up pretty nicely with that. Now that we've done the main vessel to our satisfaction, and it doesn't have to be perfect, of course, because we're not putting in a foreign body, which will have a long-term inflammatory response. So there will be positive remodeling. There will be no negative after effects in terms of modeling. So we don't have to have an absolutely perfect result. Then we're going to treat the side vessel, and unexpectedly on the second inflation here with a 2.5 balloon, the balloon burst. That resulted in a little bit of ST elevation, a little bit of slow flow. So I decided not to do anything more with the osteo of the diagonal. Normally, I would have gone on and do a cutting inflation. But I think it was, judicious perhaps not to. So then applied 2.5 by 20 drug-coated balloon. So this is, again, main side with the preparation, and then side with the drug-coated balloon, and finally main with the drug-coated balloon. 1-to-1, much lower pressures, maybe 8 atmospheres. And this is the final result. It's not perfect, but again, it's got rid of his angina. And that's the thing that we're trying to do, especially with elective cases. I mean, that's the whole purpose of what we're trying to do here. It doesn't have to look perfect. And in fact, Dr. Shin from Korea has shown some good evidence that actually, even when you don't completely fix the ostium of the diagonal, you get some positive remodeling over time with that, and you get luminal gain. So those are two cases that really serve as a prelude, I think, to a major shift in thinking about how we're going to approach these lesions. Some of you will be in the EBC-DCB study. We're really hoping that that will be something that people take to and are really interested in the coming couple of years. Thank you very much.
Thanks, Dave. Great talk, as usually. It's open for discussion, for your questions. Can I ask the first question? I really cannot wait to ask. For 20 years, you try to convince us that one stent is better than two. Does this lecture mean that 0 is better than 1?
Yes, I think it does. I mean, I think that's what we're working towards. So if you look at the downsides of stents, I mean, stents are brilliant, and when you need a stent, it's life-saving. But the foreign body inflammatory fibrous response accumulates over years, and we all know that feeling of someone coming back who had a stent 10 years ago, and now it's like this granite occlusion that's disaster, and the poor vessel is impossible now to salvage. So that's one aspect of it. And the other aspect is the inability ever to stop these people having the antiplatelets. And we all get calls every single day. Oh, neurosurgery. Oh, yeah. What do you? Have you? Okay, you got to do that. Okay. Well, yeah. You can't really stop everything because you've got a stent in the left main. Blah blah blah. And now you can just say, oh yeah, no, go ahead, stop it, do your operation. It's going to be massively liberating.
Good. AJ?
Yeah, so 0 stents, 4 vessels, very interesting. I'm curious, the audience, do people feel this is a bridge too far? So raise your hand if you think this is the future of interventional cardiology. Raise your hand if you think there's no way I'm putting 0 stents in 4 branches. I mean, a question I have, David, is the way you talked, I mean, I actually was taking down some of the quotes. There's more thinking, takes more time. Yeah. There's more prep, and it looks messy. So how much of an educational jump is there going to be needed? Because I think many people, they just like putting in a stent, sending the patient home 4 hours later. So yes. I think if you get the theory of what you're trying to do, which is awesome, yeah. How much education is needed to make people comfortable? I think there's a lot of education, but there's an awful lot of self-learning as well. So as you go, we got the mandate to be able to do this because we participated in a randomized clinical trial. That allowed us to start doing things that otherwise we might have felt a bit uncomfortable with. It's like, well, stents are pretty good, you put them in, it looks fantastic, they just take aspirin, go home, it's low event rate. Why would we embark on something else? But actually, as you start to do it, you realize the potential of this. And of course, I've shown you a couple of elective cases, but the real potential for this is in the hot cases, in the STEMI cases, for example. We're doing a study on that as well, where you don't even get the right. You put a stent in, but the vessel, you don't even know what size the vessel is in reality, because it's all adrenaline narrowed down. So you're making mistakes all the way in the hot cases by putting stents in. And actually, I think we'll be going back to remove the thrombus, give an antiplatelet agent, do a drug-coated balloon, thanks very much, and let the patient recover. And actually, we do that already a lot over the last year.
Do you think in STEMI specific platform may impact use?
Yeah, maybe. You mean the specific type of DCB?
Type of DCB,
yes, may well be, but I guess that's, for the future.
Well, it's extremely interesting, this discussion, but in my opinion, it just brings, decision-making back, because it was so easy to put in a stent. And when we started out with plain old balloon, it was actually a kind of a risk every time we did a ballooning. But then the stent came, and then we just solved everything with stents, and we forget to think about what we were doing. So this is actually bringing back the thought. I don't think it's a one-size-fits-all discussion, but it's an extremely appealing tool in the box. And I can see from all the audience, questions are actually exploding here. So they would like to have a concrete advice to this. And David Shekhan Karaman asked, what are the optimal results for a side branch osteum after DCB? How much can we leave alone?
Oh, we don't know really the answer to that. I mean, you could definitely leave alone a lot. I mean, the best evidence for that comes from Dr. Shin in Korea, who I think may be here, showing that even if you don't treat the ostium of the side branch, if it's a very narrow, 2 millimeter pinching of the ostium of the side branch, actually you get some positive remodeling, you get some lumen gain over time into the side branch as well. So probably less. You have to do probably less than we really think with the side branch.
Dave, I think next talk may give you the answer, or at least part of the answer to question about side branch. It's really pleasure to have AJ Kirtani to discuss physiology.
Thanks. Well, so I have a dilemma case, and we'll ask some questions along the way, and we'll go through this. And this is it's perfect bookend to what David was talking about before with his case. So here's the patient, and you can see there's an osteal LAD lesion. There's also this lesion in the circumflex just beyond the proximal, but there's a small ramus, and the ostium of the circumflex looks okay. Patient has angina, and the idea here is we're going to proceed with a PCI. And so here's what we see. We see this osteal LAD, we see this intermediate lesion in the circumflex. But first, speaking of the bifurcation, maybe a show of hands. How many of you want to cross over the circumflex and just stent from the left main into the LAD? How many of you want to precisely nail the ostium of the LAD? Nobody wants to. Oh, come on. Somebody wants to do it. Maybe you can't do it, but that's something we want to do. And then who wants to stent the proximal circ lesion? Who wants to do imaging? And who wants to do physiology? Okay, so we're going to show you a potpourri of these things. And so, one of the things with physiology is it's all great to talk about and say, but there is a premise or an advantage to doing it with an angiography-based system because it doesn't require you to have to wire with wires that are not really designed expressly for wiring. So this is the LAD. I think it looks ischemic, so it confirms what's going on. What's nice, if you're not used to this, is the Cathwork system, is that this is a pullback and shows you exactly at this point, which is that ostium, that's where the big drop in pressure is. You can actually, with this system as well, model this as a resistor and get rid of that stenosis virtually to determine what you're going to do. This is the circumflex. And so with this branch here, yellow, both of these two branches, non-obstructive. FFR is a 0.92. So, and also if you look at the pullback curve, which I always do, you see there's no clear area where there's a step up within the gradient. So you know that that's basically okay. This is the QCA tracing from which those FFR pullbacks are derived. Similarly, you don't really see a big difference in QCA along this area. So are you convinced? I'll give you the imaging because I know we had votes for all of these different modes. So here's what the LAD looks like. And you can see that there's a reasonable landing zone. There's some calcium at 12 o'clock. And now you'll see the plaque that involves the ostium. Here's the circumflex wire coming in. And now you see the left main. And as Gary Mintz and others have taught us over the years, it's very rare to be able to have plaque that only is in the ostium of the LAD, not involving the left main. Almost always the plaque comes back. And that's what imaging really shows us. Here's the circumflex. A little bit of calcium here. There's a nice zone here. This is that lesion, intermediate lesion, not a huge massive plaque burden. Here's the ostium, which looks okay. And so the question is how severe that intermediate lesion is. And unfortunately, imaging is great, especially if you're dealing with the left main, but it's not so great at determining the physiologic significance of what's going on. And so for those who don't believe in angiography-based physiology, here's a wire-based approach. And RFR of the circ was 0.94. This is a non-hyperemic index. So with all that, who wants to stent that proximal circumflex lesion? So nobody. So you changed your management using physiology, but the point is we know this happens with physiology, but most people don't have the time, the patience, and everything else to do it with a wire-based strategy, which is, I think, the appeal of an angiography-based one. So what we decided to do is proceed with balloon dilation of the LAD, and after doing it, this is what it looked like. No real change to the circumflex. This lesion still looks like this lesion, but we know what the physiology of that is. And so repeat IVUS in this situation, I think more for academic interest than anything else, but you see there's the lesion, and now where the circ comes in, there's still a pretty significant plaque burden, and this phenomenon of axial plaque dislocation or shifting is something that is seen. Now, you could use something like a cutting balloon or otherwise with these osteal lesions to try if you were going to nail the ostium, but I was always going to be leaning towards crossover anyway from the beginning. So there's the crossover stent. Typical bifurcation technique, you pot first, you recross second. Typically, if it's a provisional approach, it's through a distal strut. And in this case, because it was the circumflex, I elected to do a kissing balloon inflation. I think for a standard bifurcation, I usually don't do that if the flow looks good, but this is a circumflex. I didn't really want to mess around. And there's the kissing balloon. So here's what the angiogram looks like. So what's the next step? So raise your hand if you want to do physiology of the circumflex again. So some votes. What if I told you you could do physiology, but you did not have to wire it? Raise your hand now. Nobody's really convinced. Okay. IVUS of the circumflex to determine what to do. How about just stent it? This thing's been bothering you the entire case. Just stent the stupid circumflex, right? Okay. So here's the IVUS of the LAD and circumflex after the kissing balloon. You can see the distal landing zone of the stent looks great. You'll see the circumflex will come in with a wire there, and the left main looks good. We've optimized our results. We don't really have to do anything further with that. And here's the IVUS of the circumflex, where there's that calcium thing distally. Here's the other lesion that's indeterminate that's coming up. And at the ostium, it's actually pretty good, non-obstructed and open. So yeah, that took IVUS to do, and you're going to agonize over whether you should do anything or not. But I think you can easily, and by the way, because you already have the map from before, you literally just take a single picture, and while you're doing the IVUS, you can have somebody run the physiology of the circumflex to see what it looks like. And basically, it's not obstructed. So you have your answer. You didn't have to wire it. But I know people don't believe this. Here's the LAD, by the way, that's not obstructive either. But people don't believe it. So for the skeptics, part 2, there's the wire. Now, I was a little bit worried that we were going to dissect it for the purpose of this demonstration and then like have a major issue and I'd have to stent it and I wouldn't have a case to present, but nonetheless, wired it okay, and the RFR was 0.94. Okay, so very, very similar to what we saw with the wire-based physiology. And so here's the final angiogram. And I know there are people who still are annoyed by this and people who are probably annoyed by that as well. But the physiology in this case, we didn't instrument this, is not going to lie. And we were able to do the case successfully using physiology in a way that actually didn't require the wire. I didn't need to do those steps, but we did just for verification. But frankly, with the angio-based physiology, we would have had the same answer. So in conclusion, what did I want to show with this case? I do want to say that intraprocedural angiography-based physiology, it gives you a wire-free way to examine the significance of bifurcation side branches and other disease. Despite the fact that we have class 1 evidence showing the benefit of physiology, it's totally underused. And I don't think it's underused because people are skeptical of the evidence. People don't use physiology because it's a pain to do. And this allows you to kind of bridge that gap. It can influence treatment strategy, especially for a bifurcation treated with a provisional approach. Doesn't need additional wiring through stents, et cetera. And finally, rather than being competitive with intravascular imaging, it's totally complementary. In fact, you could do one while the other one is being run, and it offers additional information beyond that provided by imaging alone. So hope that case was illustrative. Maybe it won't change votes, but at least get you to think a little bit, and happy to have a discussion on it at this time. Thanks so much.
Thank you. So presentation is open for your questions. Any question from the panel, Ajit?
No, I mean, I think what you said is right, because maybe a few years ago, if you had seen that osteum of the circumflex, you would have been difficult to leave it alone. You would have changed. I think the addition of the CathWorks angio FFR is definitely an addition to the entire thing, because even you don't have to pass another wire through. You can get an FFR reading without having to do any wiring of the vessel. And that, along with the with imaging, is I think the way to go. I mean, you wouldn't touch those circumflex osteums, though it looks nasty to begin with.
Other questions?
I have a question.
Yes.
May I ask one question?
Yes.
Yeah, please.
Actually, what happened to me, previously I've done a PCI with a FFR-guided osteal circumflex artery. We left it alone, FFR was negative. And later on, the patient came back with severe chest pain with further extension of the stenosis and the ostium.
How soon was it? It was really
It was 6 months' time.
6 months. Interesting.
Yeah, so if you leave it alone, in the long run, it may progress. What is your suggestion on that?
So, great question. My view on this is that, I mean, that can happen rarely, but most of the data does show that if you leave it alone, especially if it's physiologically insignificant, then you should have a good result. The problem is the ostium of the circumflex is always this Achilles heel area. And I think that may be one of the reasons why people are advocating DCB use over there to really prevent a restenotic process. I thought you were going to say it happened acutely, in which that is one of the problems with physiology, is that it may be normal right now, but if you have a dissection that's unstable, it can close soon after. So you do have to use some judgment, but that just sounds like an unlucky case.
If I may just add one thing, there's been one center in Kerala where they did a lot of, they did some studies on patients with left main stents, and they had not crossed over to the circumflex, and they had not opened the circumflex, and they found that they had a few series of patients who came back with intimal growth on the struts of the stent, causing an osteal circumflex stenosis. What do you have to say about those?
Yeah, I'm pretty aware of that data, and you can get a look at whether that's going to happen if the strut's on the ostium of the circumflex or not, typically by OCT. But I think it needs to be validated in larger series. Most of the bifurcation studies thus far show that if there's not a flow compromise, and especially if the physiology is okay, the vast majority of those you can leave alone.
How much did you have to manipulate the drawing on the circumflex to get the answer you wanted?
So that's a great question. And everybody's skeptical of angio-based physiology will ask this. Well, how you can just tweak it and move it around and that kind of thing. One fundamental premise with angio-based physiology is you have to take a view where you see the lesion. If you hide the lesion entirely, which we all know how to do, you're not going to get an abnormal reading because the software is not going to see it. So you have to try to get objective views. In the days when we first got angio-based physiology, what I used to do is I would manipulate everything to see how I could make it mess up. Over time, you actually realize that the vast majority of the time, especially if you just inspect the tracing, you don't have to manipulate it. And that's one of the reasons in this case specifically why I showed you the wire-based readings as well. Because if I hadn't showed you the wire, you might walk out of the room saying, he just fudged the numbers.
In current practice, with your experience, what are the indications, how frequently you use it, and what can you recommend to our attendees?
So I think if there's a question of what's happening with the side branch, then it's a reasonable thing to do. For outside of side branch disease, my use of physiology is in situations where the clinical scenario, the angiogram, and the non-invasive testing either don't correlate or there's missing data. So if you have a patient that has a 70% lesion in their LAD, typical angina, and an abnormal stress test in the anterior distribution, you don't have to do physiology. You treat the patient. Because if you do the physiology and you get a weird number, you're going to be in this dilemma. But if there's discordant data, maybe it's 50%, but anterior ischemia and there's clear symptoms, that's a good role for physiology. So I don't think we need to do it in every case, but this type of software allows you to be able to use it without extra manipulation, extra time, extra whatever, and it gives you another data point, which is helpful for patients.
We have a question from an anonymous person in the audience, and it comes back to thinking. And the question is, what are the protocols for POT after DCB in one or both vessels of a bifurcation? And the answer is pretty easy, because POT is for stent manipulation, and there's no stent in these. But again, when we use the DCBs, we are forced to think.
And back to the panel, the one quick thing about that. On the panel, are you using the DCB in the side branch before you put the stent in the main branch, or at the very end after you've done POT for the final chase?
No stents.
Before the stent is in?
No, but there aren't going to be any
yours,
stents.
but you don't want any stents at all?
I don't want any stents.
What if you're going to use the stent?
But that's an excellent question, because it's most appealing to do it first. But then you actually may have dissection. So if you need to rewire, you have a problem. So it's again a dilemma. But from a procedural point of view, first the side branch with a DEP, and then a stent in the main.
David, no stents, no stents.
Yeah. Well,
But
No more questions? Thank you very much, AJ. And the last talk is about stent optimization. We always think about the best way to optimize provisional stenting. And now we have some data to support thanks to Visible Heart Lab from Minneapolis.
thank you very much to the organizers for inviting me and to Goran for building this session. Again, this is a technical issue. This is about stenting. And it's basically a talk about a trial, but it's more a talk about how do you develop a new way of thinking. This is translational. And one of the things that is really appealing in this talk is how we went from bench testing to animal lab into patients to actually discuss a pure technical problem. How should we open the side branch if we want to in a bifurcation? And these are my conflicts of interest. And most of the work was done by Professor Francesco Bossotta's group, and we worked most of the time in the Visible Heart Lab, and I'll come back to that. So this is kind of on behalf of Francesco. But the background is, this is the match classification, and in the green frame, you can see some of the things we have been discussing for many, many years in the European Bifurcation Club. And this is, should you open the side branch, do a pot, open the side branch and do a pot again, or should you go for a kissing and a final pot? And as you can see out of the frames, it makes differences in the way you open the stent struts. One of the things is actually seen over here, that when you do the side branch opening, you extract the stent from the lateral wall. This is one of the issues. In the bench test, you can see the steps in the side, in the pot side pot, and on the right side, you can see another stent deformation. So this is actually the background, but the background is even more important because it's very difficult to place the second pot balloon exactly at the carina when you have done a pot side pot. But it's very easy when you have done a kissing because you have actually covered the entire polygon of confluence with balloons, so you don't need to go so deep with a pot. And if you go too deep, you close the side branch. So it's much easier to do the kissing, and it's much more appealing. But in some reasons, maybe with drug-eluting balloons, it would be nice to avoid the kissing and just do the pot. So that's actually makes this discussion extremely important. But it was solved out of the Visible Heart Lab with implantable stents in pig hearts and a clinical trial after that. And I'll just show you the two phases because it was such a nicely developed technique for evaluating technical issues in stenting. In the preclinical phase, in the explanted Langendorf model heart in the Visible Heart Lab, we made angioscopy, make direct visualization of the stent, angiography, and OCT. And on top of that, a three-dimensional reconstruction with micro-CT. So we could do it in a pig heart, but the pig heart was not atherosclerotic. In the clinical phase, we did angiography and OCT. And in the bench test, in silicone tubes, we used OCT again, which means that we have a lot of different steps of technical issues with OCT all the way through. These are some of the pictures, the 3D reconstructions, and the evaluation was done out of these. And again, you can see that on the pot panel, the left panel, the opening to the side branch was not as opened as with the pot kiss pot, but this was just in one procedure. And in fact, the animal lab and the bench test lab was a little bit conflicting. So there was some issues very good with the pot side pot, but others with the pod kiss pod. So the conclusions from the clinical study was that there was a better preservation of the circularity in the proximal main vessel with a pod side pod, but pod kiss pod get a better expansion and apposition at the level of the distal main vessel, as well as a better side branch scaffolding. And it is actually the side branch scaffolding that is appealing when you do provisional stenting. Then came the clinical trial, the CRAPIS trial, and it was just out in JACC intervention last week by Francesco Bianchi and Francesco Bossotta as the last author. These were the inclusion criteria, exclusion criteria. It was basically stable patients, not very complex, but with complex bifurcations. What they did was they randomized 60 patients to two groups, one with crossover stenting and one with pod, and then pod side pod and pod kiss pod. And then an evaluation based on OCT in those cross-sectional areas, evaluation in a three-dimension setup. And the result came out very nicely that there was far better minimal stent expansion, maximum malapposition distance, and stent eccentricity index in the pod kiss pod group. So the conclusion was that during stepwise provisional stenting in left main of large bifurcation, the pod kiss pod sequence is associated with better stent configuration than the pod side pod strategy. It's not a large study, but it's actually a translational study from bench to animal to humans, and it supports the idea of the kissing recommendation from the EBC, which actually is based on these steps, as you can see pictured here, from the latest consensus document, the cartoon in top, the angiography in the middle, and the stent boost in the distal part. So an example of how to work in different areas to solve a technical issue when you're doing bifurcation stenting. Thank you very much for your attention.
Thank you, Jens. Presentation is open for discussion. We have two questions, Jens, for you. One is, what is the current recommendation after left main LAD crossover? Do we need to open LCX by kissing if there is no carina shift? Dr. Chang is asking.
It's a very good question, and it's actually up to the operator. There's no clear evidence that you cannot leave it alone, but many would think that it would be nice to have it opened if you need to come back in the future. But again, the provisional approach is stepwise, and there is, after each step, there is a decision making. So you can decide not to open if you find the relevant reasons for not doing it. So that is actually the main answer to that question. We could elaborate a little bit on it, because if there is some narrowing, should you then open it? And then you could actually run through all the things we have seen today, physiology, imaging, everything. But even in imaging and even in physiology, we do always have the problem that when you have treated a bifurcation, you have most often made minor dissection, edema, and maybe also plaque shift. And that is not a fixed stenosis. That may be a transient stenosis, which is actually revealed by an FFR drop, but may be gone if you leave it alone in a week. And that's the caveats of these things. So again, in bifurcation stenting, it comes back always to the decision of the operator. And the advocation is actually in the EBC to leave as less as possible metal in the vessel.
AJ, you want to ask?
Yeah, just one thing to elaborate. On the kissing balloon inflation in the trial, was it a typical sequential kissing, so side branch main together, or was it just only kissing balloon in the trial?
It was the first. And it was a very minimal thing. It was just covering the polygon of confluence, which actually you could see in the ovality index, because it wasn't there.
Dr. Henning is asking, was there a difference in clinical endpoints between two strategies?
There were no clinical this was a technical endpoint. So there was no clinical endpoints. It was not dimensioned for that. But again, as I said in the beginning, there is some technical issues. If you go too deep with the second pot, you actually ruin everything you did with the kissing. So, and this is the risk when you do pod, but no clinical endpoint here. Only
Do you
technical.
think there is specific recommendation for left main versus non-left main? Pod side, pod outside of the left main, is it okay?
I do think personally, yes. This trial was not on left main. It was on larger bifurcation. And there was, I think, 1 or 2 left main. But this is not on left main. It might be different there because the dimensions is bigger. And the takeoff is 90 degree, most often.
Questions? Yeah, please, just take the microphone. There is microphone over there.
Thank you very much for the fantastic talks. A couple of questions. The first one, obviously relevant to the side branch, but generally on DCBs. So what would be the lesions that you wouldn't consider a DCB in? For example, a calcified lesion, because we understand that if you use a DEB for a calcified lesion, the absorption, the drug loading, it might not be as effective as it is a soft atheromatous lesion, for example, which might lead this to the question of, would intravascular imaging be useful to determine what lesion would be suitable for DCB? That's question number one. And number two, what would be the indication for crossover to stenting? Because personally, I don't believe that DCB will be the complete solution to all the coronary lesions. And I totally agree that actually stents, the less metal that you use in the arteries, the better. So those are my 2 questions. The first one is DCB, a lesion subset. And the second one, the crossover to stenting. Thank you.
Great. Dave?
Yeah, so nice questions, actually. So crossover to stenting, I think, and this is the fantastic thing that we now have that in the previous era. This is what differentiates us so much from the POBA era, where it was a total nightmare. If they got a bad dissection, a flow-limiting dissection, what could they do? Nothing. Surgery. It was a calamity. So now we have much, much greater freedom to be a bit more aggressive, be more one-to-one, actually dilate the lesion, take on difficult anatomy, because we know that, okay, if we do make a mess of it, there's a stent which is going to fix it, staple it all down. So the big reasons that you would say, okay, actually I need a stent here, is either that you have a dissection that's propagating, so that that's non-localized. Because most angioplasty, the mechanism is actually dissection, but if it's non-localized and it's propagating, then you're going to need stent to prevent it keep going. And the other one is that you have dye staining that persists around the lumen of where you've been treating. So at the moment, those, along with lack of TIMI3 flow, are the key reasons to go ahead and put a stent in. And absolutely, there's going to be an instance of requiring stents, but that's the beauty of the technology we now have available. We have the stents.
Dave, very quick question for you, because Dr. Karma is really unhappy because his questions are never answered. And the question is the same old question. Is DK crush in left main better than provisional?
No.
So, Dr. Karma, you got your answer. Okay, if there are no further questions, let me conclude the session. I think this was really fantastic, as every year this session with the update on the evolving bifurcation treatment practices. What we learned today, DCB in bifurcations is promising and really increasingly established technology. EBC-DCB trial will investigate clinical outcomes following stepwise DCB strategy versus stepwise provisional for non-left main true coronary bifurcations. In non-atherosclerotic animal coronary model with multimodality imaging, pot-kissing pot strategy provides better stent expansion at distal main vessel and higher side branch scaffolding at the polygon of confluence. And FFRangio has high diagnostic accuracy in physiologic bifurcation lesion assessments from angiograms without need for hyperemia and the wire. I thank all presenters and discussants for fantastic talks. I thank you all for attending the session, and I thank you, Medtronic, for organizing this one. Have a successful rest of the meeting.